coming to talk to us about the situation in patients with family history.
Good afternoon, ladies and gentlemen. Thank you very much, Neely. First, I would like to thank the organizers for the pleasure of inviting me to this interesting and exciting Congress. So the title I have been assigned is The German Status of Moving Anti-Inflammatory Drugs into the Clinic for High-Risk Individuals. And mind you, this will be a very focused presentation, and I really need to take a little bit of time to define the high-risk individuals. The anti-inflammatory drug that I'm going to talk about, not surprisingly, is going to be aspirin. But we need to take a little bit of time to focus on the cohort that we will look into. So if we're talking about moving into clinics, we need to be really sure that we have enough evidence to do this. And obviously a lot of the data that we have also comes from these interesting mouse models. We have an APC mouse, we have a MIN mouse, which is great, but I mean, we don't have fur and we have a different diet, so we might not be able to translate everything in the same way. So actually studying interventions such as chemoprevention in high-risk individuals is actually the natural mouse model for generating data that is really transferable to the clinic. And we really need to look at the risk assessment of the individual groups. We need to calculate the genotype, the phenotype, interactions, and as we have heard before, also the environment, which we have been neglecting for this cohort. So, which high-risk individuals do we know? Well, we have the group of the hereditary colorectal cancer predispositions, and the most known ones are familial polyposis, juvenile polyposis, MYH, different types of FAP, attenuated FAP. But the group that I would like to focus on is formally designed or referred to as HNPCC. You've heard it before, hereditary non-polyposis colorectal cancer. But that actually is a messy cohort too, because HNPCC is defined clinically. Today, we would define it differently and call these patients Lynch Syndrome. So the group I would like to focus on are the Lynch Syndrome patients. Now, we all know that we inherit a variety of factors that predispose us to different things. But if we're talking about this syndrome, we're talking about an autosomal dominant mode of inheritance, which really means that 50% of the offspring and first-degree relatives will move on to have a very high risk of having cancer. Importantly, in these patients, the mean age of cancer manifestation is much younger. The mean age is about 44 years of age. Also, we have a large variety of extracolonical cancers. Worldwide, we can say that this cohort is largely under-identified. Take into account that in Germany, we have 90,000 mutation carriers for this disease, 90,000. Every year, about 3,000 patients that get a manifest colorectal cancer out of this cohort. So it's a very important group to look at. The thing is, we do not know which families actually have this. If we see a variety of cancers in a family, we will not be able to clinically really nail this to the ground, what kind of a syndrome it is. They really look quite similar. The important thing for clinicians, though, is that if you bump into a family or a person who has a phenotype that is surprising or could fall into the field of a hereditary disposition, always take the care of looking into this, because one index person, in average, will lead to 3 people who have an increased risk and will be mutation carriers. So as you all know, nowadays we can test this, and Lynch syndrome patients are those patients that have a pathogenic mismatch repair mutation. There are different genes, and actually we are really generating and evolving data to tell us these different mutations are different. You know, a mutation in a mismatch repair gene can act entirely different if it's an MLH1 mutation or, for example, MSH6. Now you can see in the numbers, and these are the numbers from the German consortium, which has been generously funded by the German Cancer Aid for many years now and has generated very important data. So you can see that you find what you look for. Obviously in the first years we've been looking for MLH1 and MSH2 mutations, and probably MSH6 and PMS2 are largely underestimated because they have a much less severe phenotype, so you don't really bump into them if you don't look for them. So systematic testing would be a way out of this dilemma, also to identify more of the patients. So what type of cancers do we see in Lynch syndrome families? Well, predominantly we see colorectal cancer, and I must agree with a speaker this earlier who said there really is a difference between colon and rectal cancer. And unfortunately, even in our consortium, we have mixed this. We're just separating it and trying to evaluate it because they don't belong together. They're different. And different than previously thought in Lynch syndrome, we do have a large amount of rectal cancers, even as the first cancer. So if you look at the cancers that we find, and this is German data, so this is what we are talking about in Germany. Colorectal cancer, about 1,200 in this entire cohort of 1,170 families. And you will see that a third of them have a metachronous colorectal cancer. So they had their second cancer already. You can see, or I would like to draw your attention to the endometrial cancer, which here has quite a low number and is largely underestimated, as I will show you. Note the large number of small bowel cancers, which is associated, and also would like to draw your attention to the bladder cancer, which is quite high. And most recently, it is also considered that breast cancer belongs to Lynch syndrome with an increased risk. So there is international data. There's an international mismatch repair consortium which has generated the worldwide data on mutation carriers. And interestingly, you can see here that colorectal, okay, is again the most predominant cancer, but endometrial is not that far away from it. Remember the German numbers? So there is great potential here to look for these patients, and this would also clearly be a group that would be attractive to consider chemoprevention. So we really need to open our eyes. We're not finding even a small proportion of what we're actually looking for. So what do we do if we know there is a family with a Lynch syndrome or we have an individual with Lynch syndrome? Well, what we can recommend is intensified surveillance and screening. So these are the new German guidelines, just released, 2013. So we do a physical exam. We recommend colonoscopy beginning age 25 once yearly, worldwide, the most intense screening program. GYN examinations beginning age 20 actually, and then starting with ultrasound transvaginally age 25. Upper GI endoscopy, please remember the numbers. They were much smaller than small bowel cancer. There is actually no evidence to recommend this. We're just checking in the entire cohort if any cancers have been detected by doing this screening, which is also invasive, of course. And very much invasive endometrial biopsy starting at the age of 35 years. Now, Dr. Ma said in the beginning, you know, people are not keen on having colonoscopies, right? Not even once a year, and not once in a lifetime, or twice in a lifetime. Now, we are talking once a year, age 25. Now, the basic problem is that this is a group that does not really have a very, let's call it, easy endoscopy. It's very difficult because these patients get their small polyps more in the right-sided colon, point 1. Point 2, they have to have them removed. We all know that we are quite efficient with colonoscopy. The problem with these patients is, though, they have very small polyps. We've heard about it during the day. They have a very aggressive potential. The interval from a small cancer from a small polyp to a cancer in this group of patients can be less than a year. Even if you're really, really pretty sure and you do a very adequate colonoscopy, long withdrawal time, you might even do chromoendoscopy. And I think that is the biology of the disease. We cannot really prevent the disease by doing these endoscopies. But if we do them, and there is a very beneficial effect, don't get me wrong, we have less cancers, we see less cancers definitely, and we see an earlier stage of cancers. So this is obviously something to do. But is frequent colonoscopy to this extent really safe? And we have to say, well, we know that we have in these patients probably a very high rate of missed polyps because of the high rate of cancers that they are getting. So we're not really preventing the number of cancers that we should by doing this. And of course, I'm showing you the worst numbers. I know there are better numbers, but I mean, colonoscopy, to get it straight, does have a risk. And especially if you're removing small polyps, the risk of hemorrhage is not small, and the risk of perforation, even if it's not large, consider that these patients will have approximately 45 colonoscopies, assuming that they're compliant, in the course of their life. And when they're identified by genetic testing and start early. Approximately 15 colonoscopies during their lifetime will require polypectomies, and they have a lifelong risk of complications, as shown in the previous slide. And despite doing this once yearly, 23% will develop at least one colorectal cancer until the age of 60, and 23% will have advanced and not early disease. So now we're finally coming to aspirin, but without knowing what happens in the natural history of these Lynch syndrome patients, we will not be able to judge if aspirin is worthwhile taking for them or not. So this is the CAP study, the CAP2 study, which has been published twice. In the CAP2 study, it's a 4-arm randomized placebo-controlled study looking at aspirin in a dosage of 600 milligrams and resistant starch. Starch did not have any effect, so I'll leave it at that. Let's look at aspirin. So 600 milligrams of aspirin daily for a period of up to 4 years, published in the New England Journal of Medicine, no effect. This was published after less than 5 years of follow-up. Continuous follow-up then led to the publication in The Lancet in December of 2011, and it showed a very clear, for the colorectum, significant preventive effect of 600 milligrams of aspirin on a daily basis. So a very delayed effect, which we have heard of previously. Now, if we look at, this is unpublished data, and this is actually the follow-up of the follow-up. The longest patients in this study now have been in the study for 12 years, and you can see very nicely here, they've been pretty close together in the beginning, and about at 5 years, mind you, most of them, the mean time of aspirin intake was 2.5 years in these patients, and then they stopped taking aspirin. So this is really a delayed effect of a quite short intake of aspirin. And you see the scissors moving apart here, and this is the placebo group with 25 the other way around. So the placebo group had 45 cancers out of 434 patients, and the other group a bit more than half. What you see also is that the main effect is actually after 10 years, but it does start with 600 milligrams of aspirin after 5 years. So we've been hearing that there's a delay of 10 years. In this study, there's a delay of 5 years. And obviously it increases up to this time of about 10 years. And we've continued to look at these patients, there's a flattening, there's a plateau. The effect drops off after this time, which is quite interesting. So actually after 2 years intake, you have about a 10-year protection. Now there's another study which shows prospective randomized data as an intervention. And this is the study from Nancy Cook, which has just recently been published last year. And it's a very large cohort of over 33,000 healthy females. And you can see it was a low-dose aspirin study on alternate days. So every second day only an intake. 10 years are entirely identical. And then the scissors goes apart. But again, remember that in the CAP study with the higher dosage, whatever it means, the effect was earlier. It was earlier than after 10 years. But these are now 2 prospective randomized placebo-controlled studies that are out there clearly demonstrating this effect. But let's get back to the high-risk group. What is the price for this obvious oncological benefit for the patients? Well, again, 90,000 people in Germany, half of them will move on to get cancer in the course of their life. Regular aspirin would halve that risk, so about 400 to 600 fewer Lynch syndrome cancers per year would occur. Again, 400 to 600 less Lynch syndrome-associated colorectal cancers. The price would be, and I'm sorry, this is the wrong way around, the price would be 9, not 6, extra hemorrhagic strokes per year, which is offset by a bigger reduction in thrombotic vascular events and about 90 significant GI bleeds versus 400 to 600 colorectal cancers. Of course, you do have to consider also the risks of colonoscopy, and keep in mind that aspirin also reduces, it's a very strong trend, it does not quite reach significance, but a very strong trend reduces all of the other extracolonic cancers. So Actually, what we need, knowing this oncological tremendous benefit, actually what we need is risk reduction strategies, and Nadia already pointed that out. I'm really excited to hear about the data from Nelly. But one of the things that we can really do now is risk reduction by eradication of Helicobacter. That's easy to do. We should do it in this group of patients. There is some preliminary data suggesting that patients with Lynch syndrome that have an HP infection move on to get more gastric cancer. Treatment of hypertension. You are aware of the HOT trial. Clearly, treating hypertension will reduce the rate of complications and side effects of aspirin. Age. These people have to start early. If we're doing the first colonoscopy age 25, we should start giving them aspirin age 25. Telling them that this is an option. Again, we heard that the older you get, the more complications you get. We have a delayed effect. Maybe if you take aspirin at a young age for 10 years, 15 years, you might have a lifelong effect. We do not know. And the other thing, of course, we do not know which dosage we need. I mean, 600 milligrams, there's no debate about this, is a very high dosage, and we need to consider if side effects are stronger and if the effect might be the same with less aspirin. And there is new data also, and there will be more to follow in the next talk, but there is also several groups that are looking at how to test the people who are most sensitive to complications and side effects of aspirin. Now, one thing I want to share with you, because it belongs into the aspirin topic, this is unpublished data. It comes out of the CAP2 study, and the manuscript is in preparation. I think it's very intriguing. 55 out of 937 people in the CAP2 study developed a colorectal cancer. This is a little bit earlier evaluation of the data at the time of the last follow-up that was published. So the relative risk in the obese was found to be 2.41, and mainly in MLH1 carriers. There was no excess in MSH2 and MSH6 carriers. But interestingly, the excess risk was confined to the placebo group, which meant that aspirin can reverse the increased effect of obesity in these patients. Very intriguing, talking about physical activity and other factors, but this is a spin-off out of the CAP2 study that I consider quite interesting. So we obviously know that aspirin works for these patients. We know that 600 milligram work, and we would like to see less work for them. So the CAP3 study that has been referred to will be launched shortly, also in Germany. And the concept of the study is that 100 versus 300 versus 600 milligram of aspirin will be randomized. You may notice there is no placebo arm. 2 years of treatment, and then a low dose open intake of 4 to 5 years, and 3 comparisons at a minimum of 5 years. Aspirin is supposed to be posted to the recruits, so this is the way. It was very difficult to launch, actually, and John Byrne from Newcastle has been, obviously, as the father of this whole idea and the study, has been deeply involved in sorting out how to get this done, randomizing the patients with tablets to take 300 or 600 milligrams, so there are different dosages in these tablets, but every patient will take these 3 tablets in the course of a day. Recruitment criteria: age over 18, a proven mismatch repair gene carrier. Well, I guess that's the most important thing. What we do want to have is, of course, he says indefinite, which I think is not quite realistic, but we'll be dead by then. But anyway, so a long follow-up is very important for these patients. And of course, biobanking will be very interesting. So thinking about this evidence, we made an online survey in expert opinion groups, which is really Insight, International Society for Hereditary Gastrointestinal Tumors, dedicated surgeons, gastroenterologists, epidemiologists, geneticists, and I would just like to show you this data. Now, this is not big science, but this is a trend of what some people, when they are asked, would do, and people who are knowledgeable about Lynch syndrome. Would you take aspirin? Yes, 81.2%. If you have chosen yes, what is your reason? Okay, most of them base it on CAP2 results, so they are informed about the study, which is nice to know. If you have chosen yes, which dosage? So 42.1% would opt for 100 milligrams. More than 50% would want to take the higher dosage. And last but not least, at which age would you begin? And knowledgeable people would really start at a young age, definitely before the mean age of the occurrence of cancer in these patients. This is about like, even this group would be like 5 years before the mean age of the first cancer, so that would probably grasp. So, what do our guidelines say, our German guidelines? So that was my assignment, to evaluate the situation in Germany. Well, in Germany we have new S3 guidelines which evolved and were published 2013. And I will translate it for you because interestingly, it says a chemoprevention for HMPCC should not be performed. Evidence level A. I don't know where they got that from. And the level of evidence is 2B. So I think that, actually I think that this really needs amendment. I showed you the oncological arguments. I mean, we do have to talk about dosage and side effects, but there will be another study. But can we wait for the answers of the CAP3 study in 10 years and not tell the patients about these results? No, I think we should stop patronizing the patients. I think the patients need to be informed about these results. I think that they have a right to know them. I also think that these patients do have a right to decide which of the risks they are more willing to take, the risk of aspirin or the risk of getting a cancer despite intensive surveillance. So in conclusion, the German status of moving anti-inflammatory drugs into clinical practice in Germany is being severely jeopardized by the guidelines. Thank you very much for your attention.
Thank you very much for this very impressive talk with very much open questions, even in Germany. But the time, unfortunately, has progressed so much that we will now come to the last lecture.